Good afternoon, everyone. We're just getting a few more people admitted. Maybe give us just one more minute and then we'll get started. Yes, Jamie Osborne, you have a question. You did have a hand up, maybe not anymore. All right, I think we're ready to get going, Helen.
Great. Welcome everyone to the June meeting of Plan, Design, and Expenditures. Isabel, can we please start with a roll call?
I will lead that one off. I'll just start with Helen Belanca.
Here.
Chan Wei Chi.
Present.
Rosemary Hemmings. You can look at the list. Nope, I don't see that person. Angela Michalik.
Here.
Thank you. And please, if I mispronounce your name, will you please correct me? Thank you. Tony German. All right. Betsy Boyd Flynn. Okay. Brian Frank. Eve Gray.
Present.
Thank you. Gabriel Andine.
That's me.
Thank you. James McGee.
Here.
Thank you. Jamie Osborne. I saw their name. I want to make sure that they're unmuted. Hold on. They had a hand up. Isabel, can you see if Jamie Osborne is on the call?
They
Or on the
they
meeting?
are on the call. I see
Okay.
them raising their hand.
Oh, great. Okay, thank you. Maybe there's a technical malfunction. All right, Julian Horner.
They will
Max.
be arriving around 2:30.
Oh, great. Max Kaiser.
Here.
Thank you. Mike Durbin.
Here.
Peter Addy.
Present.
Thank you. Peter Merritt.
Here.
Thank you. Robert Fazette.
Here, having to head out around 3.
Oh, thank you for letting us know. Tajriq Rahman, am I saying that right?
Yeah, here.
Thank you. And I see, let's see, I think we had a couple people. I think Isabel, will you unmute Gabrielle Ramirez? I believe it says Gabrielle and Dean on the meeting, but Gabrielle Ramirez on the on Zoom.
Yes.
Thank you. And if there's anyone else who you didn't hear, so if you're one of the committee members and you didn't hear us give a roll call, if you want to give a shout out, you can unmute yourself.
Everybody, Tony German.
Oh, thank you. Great. I thought we had missed someone. Thanks so much. Okay.
Great, thank you. And can we please pull up the agenda? Okay. I think it's the next slide. Great. So we will take a few minutes to review any feedback that the staff received from the last meeting. We have some committee updates and then a recap of the strategic planning meeting that the board had in June. And then one of our main goals today is to follow up on the eligibility recommendations. Our priority is to get a straw proposal for eligibility to the board for the June meeting, which is coming up next week. And then we're going to have a discussion about provider payment models and a little bit of discussion about how payment might work. The goal with that is to just start introducing the topic of provider payments. It's a very big, very complicated topic. We have a number of committee members willing to do some extra research and homework on that issue. And so our idea today is that we're just going to sort of lay some groundwork and generate a whole lot of questions and see where the holes are in the topic. So with that, I'll hand it over to staff for review of feedback.
All right. Yes, Isabel, can you go to the next one? Okay. So thanks in everyone. If I haven't had the opportunity to meet you yet, I'm Mimi McDonald, the Executive Director here at Universal Health Plan Governance Board. So hello to those who I didn't meet at the prior meeting. So things that we talked about in May, a lot had to do with the eligibility straw proposal. We got some questions that we needed additional research on. So that was around coverage for minors, people traveling or moving out of Oregon, what to do with college students who are going to school out of state, and also some questions around seasonal and migrant workers. There was also discussion around the long-term supports and services straw proposal, and there is a subcommittee that's being convened. That one is taking a little bit longer to get together. However, there was also a subcommittee that's getting together around provider reimbursement. So we have put that in motion, and they're working on setting up a specific time. So that was some of the recap from last meeting, and we'll go on to the next slide. Okay, and next one too. So one of the things that we're hoping to do, because I think it's challenging for the different committees kind of not knowing what work is happening and sort of in the other work groups or the other committees. So just briefly, one of the things I'm going to do as a director to kind of update everyone is just at the top of the meetings, kind of say what's going big ticket items happening in the other committees. So Community Engagement and Communications Committee, what they're working on is actually a style guide for all of the Universal Health Plan documents to ensure that there's an inclusive, trauma-informed verbiage. It's Kenyi has been working a lot on this, and some of it is based on the work through the OHA, but having a lot of input too from the committee as well. Also, Patty Wentz, consultant, is just about to begin working with the committee and board members on the sort of that larger communications piece. Operations Committee, always hard at work. The Milliman Consultant Group will soon begin working with the committee, providing a lot of data analysis. Right now, what the committee itself is working on is developing these questions that they can give to the consultant group, specifically around developing that administrative structure. The Operations Committee did put together a trust fund proposal, and that's going before the board at the next board meeting. And then finally, on finance and revenue, the consultant group of Eco Northwest has begun work with this committee and really has shaped up a framework over the next 7 months of a timeline of being able to go into in-depth, especially around the finance options and ramifications of what it would look like to fund the universal health plan. So things are moving along in all of those committees. Next slide. All right. And Helen, I thought for this one, if you go to the next slide, Isabel, I'll just kind of give the bullet points, and then please have you weigh in on sort of the color commentary as it were. So there was a strategic planning meeting last on May 15th. And so the whole board was there in person. It was incredible. They reviewed their core principles and are working on a mission statement that is going to be rediscussed at the next board meeting. Judy Richardson did an incredible job doing graphic facilitation to kind of bring the board along current state of healthcare, what the desired future state, and then developing that sense of these stepping stones and also process steps to get to that desired future state. So for example, some of the stepping stones, so in other words, things that are on the way to a unified financing plan, universal health plan, are things like a uniform fee schedule, or the development a single set of quality metrics that could be used throughout the state. And again, these are just potential stepping stones. These aren't specifics necessarily. Global budgets for hospitals. This is certainly something that you all will probably be talking about. Potentially developing a public option for long-term care. So these are just some of the topics that were brought up at the meeting. They also discussed kind of where decisions are, at what level decisions were being made at, and at some of the decisions, of course, committees, all the things that the committees do end up being recommended to the board for decisions, but there are probably some board level decisions that have to be made before the committees can do even further other work. And then we also did some work plan timeline updates because there's been a little bit of a delay, staff turnover and other things. So things have maybe been shifted a little bit. So we'll talk more about the specifics of that later. So Helen, like I said, mine was pretty much the bullet points. If you want to add more.
Yeah, thanks, Mimi. That was great. So the board has been going through a lot of turnaround. We lost our entire staff, executive director and our policy analyst and our executive assistant. And we've had complete turnaround of that. We're just in the process of filling the policy assistant role. In addition, there's been a couple of shifting board members. And so we took April off. We didn't meet in April. That's right when Mimi was coming on as our new executive director. And we thought that May was just a good time to just do a reset, like just get all the staff on board again and reaffirm what our mission was and outline a plan moving forward. Our work plan for the board had been developed a year ago, right as the board was forming and before we had done any committee work. So it was really time for us to look at that work plan and make sure it was accurate, add any needed changes to it, pull in sort of what is the work of the consultants now that we've got these consultant teams on board, what is their role and how does that affect our work plan and the work of the committees. And then as Mimi alluded to, really being more intentional about which decisions need to be made by the board, which do we need to field to our consultants to help us get some expertise and research and background on, and which decisions are more appropriate to happen at the committee level. So we needed to just kind of look at all of that again, and that's going to come up later in our discussion today as we get into it. You'll see an example of that. So, and then regarding the stepping stones, Mimi's right. So we, as we think about this plan, when we think, 10 years out, if this were to come to pass, it is obviously an enormous shift in how healthcare would happen, with tens of billions of dollars involved and enormous organizations and quite literally everybody in the entire state's healthcare. So more than 4 million people. So that's not going to happen overnight. There's going to be a long ramp up period to get there. And so these stepping stones, what we're thinking of is what are some discrete bodies of work that would be useful to put some time and energy into developing that could be implemented now, whether or not we had a universal health plan, and would help to pave the way. These are things that would necessarily need to exist in a universal health plan, but also would be great to have in place now, even if a universal health plan is delayed or, for whatever reason doesn't happen. These are things that we could work on. And these 4 are some examples. There are other ones, but from this committee, our work on long-term care is a really great example of that. So we agreed on this separate task force for long-term care. That is still in the works. That is still part of our plan. But, developing a public option for long-term care would be a really great sort of stepping stone, which would get us, then that could be incorporated into the universal health plan down the line. But starting off with that is great. So we wanted to have some discrete little bits of work. Yeah, so that's that would be my comment on that. Anybody have questions on that or concerns for Mimi or for I? I can't see hands, so if you're, sorry, I'm
I'm
working on
not
this thing.
seeing any right now.
Okay, cool. Then I'll pass it back
Keep
to
my eyes
you.
peeled. Oh, I think Jamie
Oh.
Osborne, did you raise your hand?
I did, thank you. I'm sorry, it
Thank
took
you.
me a while to get audio and video connecting. It said the host wasn't allowing unmuting or sharing of screens, but I think it looks like everybody else is doing fine. It was me. My only comment was how we might toggle with OHA, for example, quality and metrics committee, metrics and scoring committee, to begin that work now, to make sure that we're sort of moving that direction together rather than assuming that they're in movement in concert with us.
Yes. So we have 2 staff at OHA whose job it is to help with that alignment, to watch sort of what this board is doing and to make sure in its alignment with OHA's work. You're alluding to, of course, the CCO metrics and scoring committee, the metric set that is part of the CCO work. And yes, so we are keeping an eye on that and keeping tabs and making sure that we're in alignment, right?
Yeah, I think that's a great call out, and I'm excited. We have certainly a fantastic guest from OHA, not specifically on that topic, but definitely around this alignment as well. So thank you for bringing that up. All right, Isabel, will you go on to the next slide? I think there's just one more. Oh, sorry, this one I just put in there as a placeholder because I love it so much. This is something that Kimmy developed, which talks about, for all of your work plan deliverables, the Plan, Design, and Expenditure Committee tasks, and the overlap with the consultant groups that, of course, we have our HMA consulting and the work that they've done helping with plan design and, of course, with other committees as well, but also Milliman, which I'm hopeful that the very, very final contract revision, we just finished it last night, that they will be on board in another week or 2, but just kind of using this as a referencing that overlap and how the consultant groups are enhancing the work of this committee. And then the next slide, because we had talked a little bit about just the timelines. Now, essentially, every time I'm going to put up a timeline, I will give the caveat that it's still sort of in draft form. But as you all know, sort of plan, design, and expenditure, one, you have a very an enormous task. You have a lot that this committee is evaluating and is responsible for making recommendations to the board. And of course, some of it has been laid out in the joint task force, but of course it needs, additional evaluation and scrutiny from your part. So what you will notice is sort of some of the things that things have been moved back a little bit to where perhaps, a board final decision may not happen until January, February of 2026, but truly trying to keep this committee and their incredible work moving forward. So again, this is just pretty general, but to kind of give a sense, all right, we're working on, you'll see the main thing, straw proposal revision on eligibility right now. So that really is the first sort of very big ticket item that we're hoping that this committee can accomplish and really firm up so we can get additional, because of course, some of the finance and revenue is contingent upon work on what, who all you decide is eligible. So that's enough about that one. But unless anyone has any questions, suggestions. Great. I will next go on. Here we go. And I will turn it over to Kim Yee.
Thanks, Mimi. Hi, everyone. This is Kim Yee. As we spoke about in our introductory part of today's meeting, one of our goals for today is to be able to get everyone's feedback and finalization on the recommendations around the eligibility straw proposal. So huge thanks to Peter Merritt and Eve Gray for putting in so much work on this for last month's meeting, 2 months ago's meeting. So what we did was we took the feedback that we heard during the meeting from the discussion and did 3 things. First, our colleagues at HMA, Janine Smith particularly, put together a comparison, a side-by-side comparison of the task force recommendations versus what the eligibility straw proposal stated, and that is attached in the meeting materials. So I hope that you all will have the chance to review that. So one of the first slides that I'll show in this portion is an extract of just the main differences between the Joint Task Force report and the eligibility straw proposal. And then next, Mimi and I took a look at the existing rules in Oregon around some of those pieces in the straw proposal that folks had questions about. So for example, students who say are visiting from, sorry, not visiting, but who live in another state and are attending school in Oregon, or what the definition of seasonal farm worker is, pieces like that. So we looked at as many rules as we could. And then yesterday, so this is a late breaking edition, yesterday we had the chance to talk to some colleagues at the Division of Financial Regulation, which was very edifying. And so they were able to provide a little bit more information on some of those missing pieces too. And then finally, what I'm going to do, and this was thanks to Mimi's suggestion, is show all of those decision points on one slide. And I hope that as a group, we'll be able to go through systematically and make a decision on each of those so that the staff, Mimi and Isabel and I, can go back to the eligibility straw proposal, incorporate those changes, and then have it ready to give to the board for their meeting next week so that they can begin to consider it and take action on that eligibility straw proposal. So ultimate goal, get everyone's discussion and final buy-in on the changes to the eligibility straw proposal. Thank you. Isabel, next slide, please. So this table shows the main differences between the Joint Task Force report and the eligibility straw proposal. So thank you again to Janine Smith at HMA for putting the document together, which you'll find in your meeting materials. As I said, this is an extract from what Janine created. So the topics that the eligibility straw proposal differs from the task force report are whether or not individuals will undergo means testing, how the Universal Health Plan will deal with folks who live in or work in Oregon but live out of state, which I abbreviated as OOS. If non-Oregon residents will be exempted from a payroll tax, if the UHP will cover out-of-state care, how incarcerated populations will be covered, how non-Oregon resident students, so people who don't live in Oregon, will be covered, and how out-of-state retirees will be covered. Okay. Again, this will be, I see that there are hands up. I can't see the participant list as easily, so I might have Mimi recap this. But Jim, if we could just have a moment, the content in this slide is actually going to be repeated in 2 slides from now. So if you feel okay holding off, if not, please feel free to, oh, thank you. Okay. Isabel, next slide, please. Thank you. So based on the research that we did, we found a couple different statutory regulations. And of course, And in our discussions with the Division of Financial Regulation, as the Universal Health Plan moves forward, it may be that some of these existing statutes and rules are going to be overwritten by any legislation that comes out regarding the Universal Health Plan. But currently, here's what exists. So just to remind folks, ORS, the Oregon Revised Statutes, those exist at a state level, and those are specific legislatively established rules, whereas OARs, Oregon Administrative Rules, are relevant to specific state agencies. So OARs are nested within the ORS. So regarding the topics of who is a resident, ORS defines, there's a specific ORS, Oregon Revised Statute, that defines who an Oregon resident is. Regarding seasonal farm workers, there is also an ORS that defines who a seasonal farm worker is, but interestingly, the duration of how long they work as a seasonal farm worker to be considered a seasonal farm worker is not specified in that particular ORS. One of the follow-up questions from last month's meeting was how many seasonal farm workers exist in Oregon. The best estimates that our colleagues at OHA were able to supply us with come from a 2018 report. And so that report estimated that seasonal farm workers plus the people who live with them in their household total about 173,000 people. Of course, with the current federal environment, those numbers may be changing dramatically this year and in future years. Another question was around student health insurance, and there are specific ORS regarding how students must obtain health insurance in the state of Oregon under public universities. And then finally, there are a number of rules regarding coverage for minors or dependent children. And it was specific that this rule was about children because there can also be dependent adults who live within a household unit. Okay, so next slide, please. And again, these are all going to be summarized in the slide after this one. So the two research topics that we didn't quite find specific ORS or OARs for were if there's a standard for out-of-network coverage. So people who are living in Oregon or insured by Oregon-based companies who travel out of state or internationally, how they're going to be covered. And then, if we recall, the eligibility straw proposal recommended that the UHP contract with some sort of national coverage network. And then the second topic that needs further attention is how the UHP might deal with retirees who move out of state. So just as a reminder, we had a casual conversation with our colleagues in the Division of Financial Regulation, and they said that regarding the first one, a standard for out-of-network coverage, even though there are no specific Oregon-based rules, they said that one of the better practices might be to look at how some of the larger health systems, Providence, Kaiser, etc., Legacy, are covering out-of-network cover. And then regarding retirees who move out of state, that was sort of, they said, we're not sure. So one of the recommendations that we heard from board members was perhaps we ask our colleagues in the communications and community engagement group to consult with business and community interest groups to get feedback on this. And Jim, I see that your hand is up. Would you like to speak now?
Sure. A couple of comments. First off, I'm really glad to see, and by the way, I'm glad to be back after missing last month's meeting. I'm particularly glad to see that you recommend consulting the business community and the interest groups. And I would recommend seeing how some of your employers handle out-of-state employees and how differentiating between in-state and out-of-state in terms of level of coverage, because the in-state might be a whole lot better, how that might impact recruiting at the business level. But one of the things I wanted to talk about is the retirees who move out of state. And one of the interest groups you might want to talk to is the state employee benefit plans. And there's probably some retiree associations connected with those plans, and get a sense, because I saw that thing that says live in the state for 50%. I assume that it might be referring to out-of-state retirees living in Oregon, or is it Oregon retirees living out of state? Retirees don't, maybe they go like 3-4 months as snowbirds, but I think just as likely is a permanent change of residence. I think you really need to do a little more digging in that space.
Thank you, Jim.
Can I jump in there, Kim?
Yes. Yes,
So,
thanks, Helen.
yes, Jim, first of all, welcome back. We are so glad to have you back. I didn't see you on the roll call, but yes, thank you. We're glad you're back. The out-of-state retirees, so you're right. So the 50% or 200 days rule is like what would qualify you as a resident. So I think originally we were saying you have to have at least half of the year in Oregon, but the ORS requirement for what it means to be a resident in general, how we define resident, is 200 days a year. So we should look at revising that. What we're talking about here with these retiree benefits, there's not a day requirement. It's just if medical benefits are part of your retirement package and you choose to move out of state when you retire, we would be denying those retirees that benefit. And so how do we compensate for that? There's no assumption that they would spend any time at all in Oregon. I agree with you. It's likely that it's a permanent move. But we don't want to deny people that benefit that they've earned inadvertently, of course, but how would we compensate them for that benefit?
Thank you so much, Helen, for weighing in. And then Chunwei Chi.
I have a clarifying question. One category is private company corporations. In Oregon, they may hire foreigners who are on B1 or B2 visa. So are they qualified as resident or not? If not, then we haven't addressed this category of workers.
Mm-hmm. That's a great call out. Yeah, we need to add in something in there about immigrants, if they're on a work visa or student visa or recent immigrants.
Yeah, particularly important. A lot of corporations, even companies like Nike and Adidas, they hire a sizable international workers who are non-citizen but who live here.
Yeah.
Thank you so much for adding that to our list of considerations. Peter and Eve, I see your hands up, and I wonder, Isabel, can we go one more slide down, please? Because it'll encapsulate all of the content. Okay, thank you. I think this will help everyone see the big picture. Oh gosh, I don't know whose hand was up first. Eve,
Eve was first.
Okay, thanks, Peter. All right, Eve, please.
I wonder if we should just change the language instead of using the term resident, if we should just say people who reside in Oregon, because we were not trying to refer to someone who has a legal status as a resident, but someone who is physically in the state for at least half the year, regardless of immigration status.
Thank you. So Eve, let's keep that in mind as we go through some of these sort of next step edits to the proposal. And so Isabel, thank you for managing our notes. Eve, I hear your call out. Thank you for that. And let's add that to the list that we'll discuss today. Oh, Peter unraised a hand. Okay, I think Jamie Osborne, you are next.
Thank you. I just wanted to also add another group of people that we might not have considered for eligibility. Can individuals who move out of Oregon purchase coverage for 30, 60, 90 days. The way that many employers allow you to continue your medical coverage while you change employers. Would there be a similar sort of model that folks who are moving out of state and might not be eligible for Medicaid benefits in the new state or employer-sponsored benefits in their new state, could they still continue to purchase, and would that maybe help also generate some revenue?
Thank you. Yeah, something similar to COBRA. Thank you. Okay, Jim McGee.
So this is probably a bit of an obscure point, but many years ago I was in the building trades, and the building trades have something called reciprocal agreements with other locals that they work out for when they hire people from other locals to work in the local jurisdiction. I think one of the interest groups you might want to reach out to is that one.
Okay, thank you, Jim. All right, and Peter Addy.
Hi, just a kind of a question or a clarification. In the slide before this, there was a recommendation to consult business community and interest groups, but we're finalizing the straw poll to go to the board for next week. So when will we be consulting with interest groups, and like what is the scope or the timeline about like that?
Okay.
Thank you, Peter. Yeah,
can take
Helen,
that.
go ahead.
Yeah.
Thank you.
So it's it's a little bit of a complicated process. It's a great question. It's a little bit complicated process, but what we're putting forward to the board is a straw proposal, meaning it's not a final proposal. It's like, this is the direction we think we're going. We need to have enough information in it so that our consultants can put together a financial plan, like how much would it cost to cover this many people. And so it has to be, enough there, but it doesn't have to have everything addressed. And then at some point, we're going to have to reconcile all the proposals, not just from this committee, but from all of our committees. And so we're just going to collect the straw proposals. This is our best thinking on this topic so far. And then in the reconciliation process, we can fine tune it. We have a community engagement committee and they have a consultant, and their job is to talk to various interest groups, including healthcare executives and healthcare industry folks, and then the business community, large businesses and small businesses, the tribes. And there is a very set limited number of meetings that they're going to have. It's going to be like one meeting for each group, or like 2 meetings maybe. And so what we're doing is building questions that we have for that group to inform our final proposals. And so I don't know when those will happen. We're not ready to launch those yet, but sometime maybe in the 6 months, those will start happening. And we're just lining up some questions for the business group. So engaging those groups with helping us make some of these decisions is going to increase our buy-in, and also likely give us a lot more sort of reasonable solutions for some of the questions that we're having. As several people have mentioned, I'm sure this has been thought of many times before in previous iterations of health insurance. And so, we can just, mine their knowledge for how to solve some of these problems. So we'll come back to it, but we just need to have enough there for our consultants.
Yeah, that makes sense. I remember the straw poll for the behavioral health. So when we're talking about interest groups, like, sure, business is great, but unions, we need to talk to unions, particularly food handler unions. I would butcher the Spanish, but PCUN is the state's largest Latino union. Migrant workers are often, not always, represented by unions. And so we need to not just do like business interests, but also the actual workers' interests.
Yeah, the interest groups that we have to engage with were defined in the legislation. And then the task force had the role of broader public engagement, which they did a great job of, and, did a lot of outreach for. So we have limited money, time, and capacity to engage sort of the entire population of Oregon. And so we have very named interest groups that group has to reach out to. So yes, I agree with you. Unions, in theory, should be in there. I don't know if that's part of their plan or not. But yeah, as part of reaching out to the business community, I'm sure unions will be involved somehow.
Okay, I hope so.
Thank you, Helen. That was much more eloquent than I was going to answer. Chun-Wei Chi.
One potential issue we may consider in the future. And then, so perhaps we can put a note that is, after the universal health plan is implemented, potentially there might be other states also implement, particularly our neighbor, Washington State, who are on the same progress. They might move a little bit ahead of us. So what I'm suggesting is, when there are other states, such as Washington State, also implemented a universal health plan, one potential strategy is for Oregon to negotiate, say, with Washington, a reciprocate relationship, meaning our beneficiary. So the term beneficiary is more inclusive because it's not about eligibility. It means everyone who covered under the Oregon Universal Health Plan. So our OHP beneficiary, if they travel to Washington, let's say hypothetically Washington State, if they travel to Washington State, or they not permanently move, but they live in Washington State for a few months, and then the potential is to negotiate a reciprocate relationship with Washington State, that they will be covered under their services, and vice versa. For Washington State Universal Health Plan beneficiary travel or visit Oregon, they will be covered under our plan. So that's something to consider in the future. And there might be more states other than Washington State also implement a universal health plan.
Thank you. I don't want to steal Mimi's thunder in case Mimi wanted to talk about this, but we have restarted our conversations with the Washington State Healthcare Authority and their equivalent group as ours. It's a commission for Washington that's also working on universal health coverage, and that is an idea that's been brought up as sort of more collaborative, communicative model. So thank you for that. I don't want to detract our conversation too much from the goal at hand, but Mimi, if you wanted to jump in with anything about those meetings with Washington, please feel free.
No, yeah, we are very glad to have been being able to reconnect with the team in Washington, and also we are in conversation with, it's not quite the same thing in California, but somewhat similar. So kind of keeping those lines of communication open and ideas as well. The only other thing I wanted to add to this discussion is, as Kim alluded to, that we did get to meet with our colleagues from DCBS over in the DFR, which I always forget the acronym for, but they are, of course, in charge of oversight for commercial insurance, and they are actually, there are a lot of policy experts on their teams, and we are going to be able to work with them too. So we're finding some of those, I think that the questions around the labor unions, I think those are all really good. And so being able to find out dive into more detail about what is happening currently in the state and how are those questions already being addressed, because certainly people are moving in and out of states and having coverage with specific unions. So just wanted to say that it's just like another, not really a consultant group, but another area within the state that we're able to tap into and really get some specific information.
Thank you, Mimi. And then one final thing, I see Tosh, your hand is up. One final thing I wanted to point out is that Ellen spoke earlier about how these straw proposals are all going to be compiled and sent to the board and shared with the consultants. And Isabel and Mimi are very kindly working on creating a public repository of all of those documents so that we won't need to hunt and search through the various committee meetings and the board meetings to find them. And so stay tuned on progress for that. But as a library lover, I am exceptionally excited to know that there will be a central repository for those versions. Okay, Tosh.
Yeah, can you hear me okay?
Yes, thank you.
So one thing, international students are required to buy coverage through their tuitions and fees or whatever. So I think that could be something that we can continue to allow for out-of-state students and international students to pay those fees, and that could be generated revenue towards the health plan. When I traveled internationally last time, I had to buy, I bought international travel insurance. And I wonder if that's a way that we can utilize and then have someone take care of that when people travel internationally instead of managing the logistics and operations of that. The other thing, just wanted to make a quick note. When we think of people who go out of state or come to our state and access healthcare, sometimes we try to think that they are like very like urgent healthcare that they need, but that's sometimes not the case, especially as I work in oncology. I see people who live in other state for 6 months and they do continue their cancer care there. So something to be cognizant about, and maybe like what kind of negotiations we can build and relationships we can build with other health systems. Being the sole provider in Oregon, we may have a lot of negotiation power to like bring down the cost of those healthcare down.
Thank you, Tosh. I appreciate that call out. Okay, if are there any other comments on considerations we might add as we go forth and make this next round of edits to the eligibility straw proposal? Okay, thank you. So I see no other hands up. For approaching the decisions for this next round of edits for the straw proposal, the eligibility straw proposal, one method that I was thinking is, one, I'm going to recap the considerations that folks brought up in this discussion. And two, it looks like there are 7 topics listed under this table that would benefit from this committee's decisions for this next round of edits. The ones that have asterisks are the ones that we're going to move to consultation with other business and interest groups. So the topics that I think we can weigh in on today for these edits are means testing, working in Oregon but living out of state, whether or not non-Oregon residents would be exempted from a payroll tax, how the UHP might cover incarcerated populations, how the UHP might cover non-Oregon resident students, seasonal farm workers, and minors or dependent children. Helen, yes.
Kim, can you just clarify? I thought the second and third one were the same thing. That the idea of the second one, the work in Oregon but live out of state, is the exact same thing of what's listed number 3, and meaning that we would address them the same way. That if you're not living in Oregon but you're working in Oregon, that there would be some sort of contract, like some sort of broker situation or stipend for paying for health insurance.
Well, Helen, I absolutely love simplification. And so if we choose to address them the same way and you as the interim chair are making that recommendation, I am so happy to simplify it.
I want to make sure I'm not missing anything. If anyone can chime in, if there's a difference between those two that I'm not remembering, I thought they were the same, but if there's a difference, please shout it out now.
Eve, I see your hand up, please.
Thanks. I agree that they're the same in my mind in terms of how they'd be handled.
Thank you. Tony.
Is supporting that approach.
Thank you. Okay. And so returning to how I thought we might address these, as we can see, there are actually a number of Oregon relevant rules, statutes, and administrative rules regarding a lot of these topics. And so if it is okay with folks in this committee, I propose that the staff will amend the eligibility proposal to add the specific wording and citations to the rules and statutes that exist. So for example, the topic of exempting non-Oregon or folks who work in Oregon but live out of state, we would add wording that says Oregon revised statute, sorry, I don't know, 316.027.1AB defines someone who lives in Oregon as maintains the permanent abode in Oregon and lives more than 200 days of the tax year in the state. And furthermore, this eligibility proposal recommends that employers and employees pay a reasonable tax to fund a state contracted health insurance broker, Peter, your hand is up.
Yeah, I guess I'm just wondering, like, are we? I think in the straw proposal we had initially identified a different number of days other
Yes.
than 200. So are we
Yeah.
saying that we are going to kind of default to this existing rulemaking of 200 days?
That's my recommendation. It's it would be in alignment with ORS that currently exists. So, and it's not too much of a difference. It was like 183 days versus 200 days. Yeah. Thanks, Peter. And I know that you and Eve worked hard on the proposal. 183 is in fact 365 divided by 2 and rounded up. Yeah. So, just wanted to explain the rationale behind that.
Sure.
Yeah. Does anybody have feedback on that proposed approach? So staff will go incorporate the Oregon relevant rules into the straw proposal, and then share it with the board. And then the other topics that came out of this conversation were Eve had asked if we want to define residency, so if we want to use that ORS that defines who a resident is, or if we want to use a more generalized statement around anyone who is living in Oregon, people living in Oregon are covered. I think for defensibility, I would recommend that we use the ORS that defines Oregon resident. So Eve, that's how I would respond top of my head off of your comment. I believe Jamie had a question about COBRA equivalent benefits. So how someone who is leaving their employment in Oregon would then have the ability to purchase temporary coverage. I could look into whether or not there are statutory rules around that. And if not, that may be another piece that we move into the additional considerations piece, additional consultative piece. And then finally, Jim McGee asked about whether or not we could put language about reciprocal agreements into the straw proposal. Helen, I might default to you about whether or not that level of detail will exist in the straw proposal. And then I do see that Jamie and Peter put hands up. So Helen, maybe could you weigh in really quickly about whether or not?
So we certainly can put that in there. I think that's pretty reasonable. And then, our process is that the board would review the straw proposal and then adopt it or modify it or send it back for further work. So yeah, if the board has concerns about it, I think they would raise that, but you can put it in. I think that's fine.
Okay, thanks, Helen. All right, Jamie, your hand was up.
I just wanted to call out, we went past this fairly quickly, but when I'm looking at the definition of a resident, it would mean that no unhoused Oregonians would be included. So
that's interesting.
Misunderstood.
No, I definitely see that point because you are right, the ORS says maintains a permanent abode, and permanent abode is itself not defined within that statute. Thank you, Jamie. I am not sure. I'm actually not sure how I might respond to that, but maybe Peter, I'll let you go first, and I'm going to churn that in my head while Peter speaks.
Yeah, I just wanted to kind of similarly confirm that if we're using the existing ORS and kind of referencing that as our definition of resident, I want to confirm that existing ORS includes individuals of any immigration status when kind of making that qualification for resident, because as in reference to Chenwei's question, it is our intention to kind of include folks of any immigration status as long as they're living in Oregon.
Peter, I did actually think about that when I was reading through the ORS, and it does actually seem surprisingly inclusive, meaning it doesn't say you have to have any documentation of citizenship or immigration status as part of that ORS. So I think that the day limit is certainly a rather deterministic restrictor, but there weren't any other written rules around, aside from living in the state, you must also have X, Y, and Z. That didn't exist. So actually, my read on it was fairly inclusive. Yeah, Jamie?
I may be misremembering, but I think a couple of meetings ago, we suggested that the question be, do you reside in Oregon or plan to reside in Oregon more than 200 days a year? And that would qualify as someone who resides in Oregon. And that's a very, very loose and open definition. But I think we were trying to err on the side of inclusivity.
Thank you, Jamie. Yes, one of the earlier drafts of the STAR proposal did talk about at least folks who are on Medicaid and Medicare, that they provide attestation within 30 days. That particular section, I believe, was modified in the proposal, but I'm curious how other people might weigh in on the inclusivity of defining residence or attestation versus when we spoke to the Division of Financial Regulation, it did seem, and again, they're a very policy related body, but they seem to be in support of being consistent with existing rules, with the knowledge that any UHP related regulations and legislation might overwrite those rules. Mike, I know your hand's up, but I'm going to let Mimi speak first. Thank you.
Oh, I was just going to pop in. Isabel, if you let me share my screen, I have the ORS pulled up, and I think that it might help actually answer one or two of the questions. I'll keep talking amongst yourselves.
Thank you. So, oh, wait, Mimi's pulling up a screen, and then we'll go Mike and Eve.
I wonder too if Janine, you'd be willing to weigh in on the rules about attestation for Medicaid and Medicare.
And so just to kind of point this out, I think that in the initial part, purposes of this chapter, resident means an individual who's domiciled in the state, unless they don't have, and then they have all these other things that mean that they are not domiciled in a state. But I don't, so I think that is kind of the heart of it, is unless they are living somewhere else. So I think it is fairly open. To Kim's point, is there isn't anything about proof of citizenship or other things, but that's just an initial purview.
Thank you, Mimi. Okay, Mike and then Eve.
Thank you, Kim. So I want to come back to the 200 versus 183. And I really didn't want to, but I do kind of wonder if there's a difference with what they're using the definition of domicile or resident for, because my kind of, knuckle dragger understanding is that it's for tax purposes, but I don't know what kind of tax, because right now we're proposing it goes through employers and through employees, like a FICA type tax. In that case, they're always going to have that taken out of their paychecks, or the employer is going to be paying that, as opposed to an income tax where you have to file at the end of the year, show that you resided. I do wonder if the intent of how they've defined this ORS is different than maybe the way we're trying to use it.
Okay, thank you, Mike. What would you like to propose? And this is somewhat putting you on the spot. Again, I'm open to everyone's feedback today. I'm merely trying to get us to, sort of a next plan of edits for the straw proposal. But if
John.
Oops, sorry. So if Mike or anybody else wants to propose an amendment to the how residency is defined piece that contains justification so that the board can understand why this is being proposed in the straw proposal. I would love to include that as an edit. And then, and Eve, I know that your hand is up. Thank you for waiting.
So I'll defer to Eve actually with that question. You're putting me on the spot, but I know that Eve and Peter worked on that. And they may have a better understanding of that than I. Well, I know they have a better understanding of that than I do.
Okay, thank you, Eve.
My general sense is that the difference between 183 and 200 days is only 2.5 weeks of the year. I doubt many folks would be caught in the middle of that. So if it's easier from a regulatory perspective to make it consistent across statute, that's probably going to just make the overall proposal easier to swallow. What I would recommend is that in our straw proposal, it reference the statute and then specifically call out that this is regardless of immigration or housing status. And then it's very, very clear, regardless of how someone might interpret the law that's on the books today, it's very, very clear what the intent is in terms of our proposal.
Thank you, Eve. I really appreciate that. I have written that down, and that sounds like a really succinct and defensible suggestion for this proposal. Thank you. Isabel, could you please, and Jamie, I see your hand is up. Isabel, could you please return to the slide that shows the totality of changes? And that might help our conversation. Thank you. Okay, and oh gosh, return to the list. Oh, someone's hand went back down. Did that hand want to go back up? Okay, thank you. So I'm going to recap the changes that I've heard. And then if anyone disagrees, please feel free to pipe in. Otherwise, I will make these edits and then get the straw proposal to the board for their meeting next week. But regarding means testing, the task force and the eligibility straw proposal had slightly different decisions. I'm going to retain what Eve and Peter suggested in the straw proposal, unless anyone has a difference of opinion regarding means testing. Pause and wait for hands. Okay, thank you for.
Sorry, I couldn't get my hand up.
I paused long enough. Thank you, Helen.
You're suggesting, I just want to make sure I'm clear that you're suggesting that we leave that they need documentation within 30 days?
Yes, but Helen, you are the board chair, and so ultimately this decision is going to sit with you too. So
I'll remind folks that we do have different benefit availability for folks who would currently be eligible for Medicaid benefits. They're going to get a slightly different benefit package than the rest of the universal health plan, and so we do need that documentation. And then certainly there are rules around Medicare eligibility that you have to provide. And so for both Medicaid and Medicare, some sort of documentation is necessary. So yes, I'm in support of leaving the eligibility straw proposal wording there.
Okay, thank you, Helen. Peter.
If there's no argument there, then I don't need to get into it.
Okay, thanks, Peter. And thank you again to you and Eve for all your hard work. Thank you. Okay, so the next topic was around Oregon residency. And so I will add in the wording from and cite the ORS 316 and then leave the remainder of what the straw proposal suggests for that topic. For coverage for folks who are traveling out of state, we are going to amend the straw proposal so that it will mention that this topic is going to be researched by the communications, community engagement and communications committee with focus groups. If this group desires, we can leave the recommendation in and say that, the Plan Design and Expenditures Committee considered that one approach could be to contract with a national network, so that that particular line of thinking isn't lost. Jim, I see your hand up.
Did you call on me?
Yes, I did.
Okay. So I'm a little bit confused why we would want to involve a insurance broker. If we are essentially an insurance plan and we contract with a national network for non-Oregon participants, why would we want to involve a insurance broker unless they happen to be the network provider? But
Eve, I see Eve's hand up, and Eve looks prepared to respond to you, Jim.
I think our concern was that the rates of payment within the universal health plan will almost certainly be below the typical commercial rates. And if as an Oregon resident, you're traveling and you go as an out-of-network to an out-of-network provider, that provider is just going to charge you whatever they want in balance billing after the plan pays. So the concern was that folks would get stuck for expected or unexpected medical expenses while they're traveling, would get stuck with very, very large medical bills. And that if you contract with a network, then there's going to be negotiated rates, co-pays, deductibles that help to protect residents financially when they're traveling. So that was the rationale.
well, I understand the network part. I'm confused about the insurance broker part.
The insurance broker is the line up. So that's for someone who is working in Oregon but lives out of state. So they would need an insurance plan in another state. They
Why?
can't be
That's
part of
the
our
part
plan. And
that's
then
the part
the
I'm not getting. I'm not getting the why.
Okay.
I think, Jim, it sounds like what you're saying is why can't people that work in Oregon and live in other states just be on the universal health plan and use our contracted national network that we're going to use for Oregon residents that are traveling out of state?
That's exactly what I'm saying.
Yeah, and I think the assumption is that the national network is something that would probably be sufficient for Oregon residents when they're traveling out of state, but probably not something that someone would want to use as their primary plan, if that makes sense.
And I think we also were given the assumption that this is supposed to be for Oregon residents and not tied to employment. So if we are covering folks who are living out of state and working in Oregon, it is now a plan tied to employment and not a plan tied to residency.
Okay, all right, I like that explanation.
Thank you, Eve and Peter. Yeah, Eve, your final explanation was very much hit the nail on the head. So thank you. Okay, the next topic is people who are incarcerated. So there is an OAR related to the Department of Corrections around the services that can be covered. And again, any UHP related legislation may override that, but I will at least cite the Oregon administrative rule that exists so far around the level of healthcare services and reimbursement for populations within the correction system. For non-Oregon resident students, I'll amend the language slightly to include verbiage from the existing Oregon Revised Statute around coverage for students in public universities. For seasonal farm workers, I'm going to leave the recommendation in the eligibility straw proposal and add the verbiage from the ORS that defines a seasonal farm worker. And for minors and dependent children, I'm going to leave the verbiage in the eligibility straw proposal and include the additional ACA and PEB rules for dependent children who are 26 years or younger, and then OHP and CALM for people who are less than 19 years old. Okay, so that was the summary of changes. And then I'll add placeholders for a COBRA equivalent coverage, temporary coverage, and then Jim's idea about reciprocal agreements. Okay, are there any other, anything that I missed in that summary? I'm pausing for longer this time. Okay. Helen's dog weighed in. I couldn't translate that very well, but I think that sounds like a good plan. So I will go ahead and make those changes, and I'll share a copy with Helen and of course the staff, and we'll have that ready for the board's meeting next week. So thank you, everyone. Thank you so much for helping me move through this conversation, and I think we're ready for the next piece. Thanks, Isabel.
I think I'm going to hop in here because this discussion, which was great, went over a little bit longer than we thought. So since our next sort of two topics all about provider reimbursement models, and we have our consultants from HMA and also a guest speaker from OHA, I would suggest that we all take, it's actually just going to be a 9-minute break, a little 9-minute stretch break. We meet back here at 2:20 and start right at that time from hearing from our friends at HMA about CCBHCs, ACOs, and then on to PCPCHs. So everyone take, sorry, now you only have 8 minutes. See you back at 2:20.
Hey, Mimi, can you hear me?
Yes, I can.
Okay. Thanks.
All right, everyone, welcome back. I'll wait and make sure that Helen has made it back.
I'm here.
Oh, she's here. Excellent. All right. Well, thank you, everyone. Thanks for the great work that we just went over on our last topic. I'm delighted that we have our partners from HMA. Janine Smith is going to lead off talking about certified community behavioral health clinics with a specific emphasis on the provider reimbursement models. So Janine, I will let you take it away.
Thanks, Mimi. Isabel, are you advancing slides? Yep. And so we wanted to present to you today a couple of existing payment models that are going on in Oregon and as well as nationally, and just to take into your consideration as you think about the payment approaches for the Universal Health Plan. So I'm going to kick off with on the CCBHCs, or what are called Certified Community Behavioral Health Clinics. And then I'll turn it over to Anya. Next slide, please. So what is a CCBHC? Cheryl Ramirez, who used to be on this committee, is very familiar with these as the director of the Association of Community Mental Health Programs, of which many of her members are CCBHCs here in Oregon. But it's a specially designated clinic, or a clinic designation, to provide comprehensive mental health and substance use services. And they're to serve anyone who walks in their door, regardless of diagnosis or insurance. That's the official definition. The concept started in 2017 with a demonstration across 8 states, of which Oregon was one of the original states involved in that, both in the planning and then the first set of sites that were CCBHCs. SAMHSA, the Substance Abuse and Mental Health Services Administration, developed the certification criteria that then each state develops their own, but it's basically basically built on the SAMHSA criteria. And it uses a Medicaid prospective payment system, or what's called PPS, which is very similar to what our community health centers or what are called FQHCs use. So that kind of makes these community health centers that are focused on mental health and substance use like those in terms of how they get paid through in the Medicaid program. There are 18 states now from the original 8 that have state certified CCBHCs as part of their Medicaid program. And then there are other clinics in addition to that nationwide that get, there was a couple of rounds of grants to be given out to expand more CCBHC sites. Overall, right now, there are 500 of them across the country that are either through the state programs or through those grants, including in DC and Puerto Rico, almost all the other states. Next slide. So the entities that are allowed to get certified must be a nonprofit organization or units of local government, such as our county-based behavioral health programs are many of our CCBHCs here in Oregon, or part of the Indian Health Service tribal organization. They have to meet 6 federal standards and provide 9 types of services, and those are outlined in the box on the blue. As you will see, many of these are very similar to some of the standards that our OHA speaker will be mentioning, are somewhat similar to our patient-centered medical home requirements. And actually, some of the PCPCHs are CCBHCs, just to throw a lot of acronyms at you. But the emphasis really was to ensure that there's integration of primary care and behavioral health. Oregon actually requires our CCBHCs to be offering at least 20 hours of primary care inside these centers. This is really valuable for a lot of patients especially with severe mental illnesses. They often really associate closer with this type of clinic, with a community behavioral health clinic. And so if they can get some of their behavioral health services there, then you're more likely to, which often are not always addressed in that population. It is really a nice way to ensure that they're getting some of their primary care physical health needs met, as well as their mental health and substance use issues. That they're supposed to be coordinating with any local primary care sites and hospital partners. They're supposed to use evidence-based practices. They're supposed to have access 24 hours, and some of them do interact with the 988 system in order to be available for a crisis. Next slide. So they're paid on a daily or monthly cost-based reimbursement, or what's called this PPS. So the services that are designated, or the services that are designated as CCBHC services. So they actually, it applies to those for example, in Oregon, it applies to those who are a member to a CCO. The clinic would bill the CCO for their services, and then they would submit a billing, and they work with the state to determine if they're getting paid up to this rate that has of their costs of their PPS rate. And if not, then they are sent money on a quarterly basis with to bring them up to that PPS rate. This allows some additional dollars to go to these clinics to help expand those services, bring in staff, do better outreach, etc. So it kind of augments the basic fee-for-service system that they're getting potentially paid, and how they're being paid by the CCO, or how they're being paid by the state if it's a fee for open card. And then, as I mentioned, there's grants available that have been given to some sites, but they only last about 2 to 4 years. And so then they need to consider whether their state, if you look at it nationally, are going to fold that into their Medicaid program or not. There's been studies on the national impact of CCBHCs that's outlined here in this green box, with having seen that there are more people being served since CCBHCs have been in existence. There's more offering of MAT, medication assisted treatment, and versus just overall SUD treatment facilities nationwide. As I said, they're working in partnership often with and quite a majority of them with their suicide and crisis lifeline call centers nationally. They often provide even some services on site in schools and childcare or other youth serving settings. And then they have close partnerships with those that are justice involved, and help to support the creation of new positions within the centers themselves. Next slide. So we have them scattered. There's about 12, I think, when I counted, with a couple on some grants. So we see them down the I-5 corridor, out in the Gorge, Eastern Oregon, and Central and Southern Oregon. So next slide. And then there was this legislature commissioned a study of, to direct the OHA to do a study of the CCBHCs. It quantified the amount of wraparound payments that were going out for those additional services to bring them up to that PPS rate. The program, at least for that biennium, had served up 35,000 individuals, mostly adults, but some services for children. At least 50%, almost 50% was mental health treatment, 15% SUD, and 11% peer and family support. They overall found, and this was a study done by PSU with the Center for Evidence-Based, with CORE, the Center for Research at Providence, worked together on this. And when they compared the overall members that were being seen in the CCBHC to the overall CCO member population, they were actually getting better outcomes on the quality measures, even though this is often a much higher acuity individual that is going to a CCBHC. There was some greater utilization because of this higher acuity of EDs and inpatient stays, but they saw a greater reduction in the rate of inpatient stays and emergency department visits. And this is what they felt accounted for the annual cost savings of $7 million in that second year of the biennium. Was that at least the rate of them going in was less, even though overall they still used those services. So I think that might be my last slide, but I think again it's just so it's one of the federal programs that Oregon has adopted to fit Oregon, and is a means of getting some additional payments to the for mental health and behavioral health services, which I know is a priority for this committee in the thinking about the benefit package. But it is a mechanism for that payment. And I see Helen's hand is up.
Thanks, Janine. This is great, really helpful. Can you clarify where that $60 million in wraparound comes from exactly? Is that from our Medicaid pot of money? Is that federal money? Is that purely state? Where is it?
Well, there was some federal money initially, fairly extensively when it first started, and then there needed to be an influx of dollars from the legislature itself to continue the CCBHCs. So it is so there is tax dollars. Those are tax dollars.
General fund dollars?
I thought some of it was, I didn't see the breakdown exactly of the 61, but I can find that out for you.
There isn't a federal, like, I thought the FQHC wraparound dollars came from the Bureau of Primary Health Care, like that was federal dollars. And there isn't an equivalent that
Well, there was the CCBHC program, and there may be some experts on your committee that would know precisely, but there, it was a special program through SAMHSA, and so those, like the grants, came from federal dollars entirely when we first started. And then as it gets adopted into the Medicaid program, there was a portion of, I think I saw in that the full PSU report, they do talk about some supplemental state dollars that needed to go in to match the federal dollars.
Okay. All right, thanks.
And Dr. Chi?
My question is also related to the funding, particularly federal funding. So is the federal funding for CCBHC is part of Medicaid funding, or is a separate line item funding? And a related question is, given the current administration's dramatic cut of mental health funding and services, how is federal funding for CCBHC affected?
I haven't seen that notice that those have specifically been cut. I think it is blended into the Medicaid line item. If you think about what you guys have been doing in the Finance and Revenue Committee that you're on, I think it's inside the Medicaid bucket of dollars. But as far as the future of CCBHC money from SAMHSA, I know there have been cuts to SAMHSA, but I haven't seen, I haven't read the $1,000 page bill yet, or seen the budget detail to see if what the future of it is at this point. I think some of that's all in flux, of course, as it goes from the House to the Senate. Eve, you had a question?
So in terms of funding, I can speak to FQs better than CCBHCs because we are not yet a CCBHC, but we are an FQ. There is a base grant, which is a federal grant from HRSA for FQHCs, and then it's Medicaid funding, which is the mix of state and federal dollars for the remainder, and that includes wraparound payments, that those are a mix of dollars. I do think that something for us to keep in mind as we're looking at these specialized medical home type models is that though the universal health plan will solve some problems related to access. So if the problem is that someone doesn't want to accept the payment for Medicaid, it will help solve that problem. What it won't solve is someone who's unhoused and can't make an appointment consistently getting dismissed from a practice because, or someone whose behaviors related to their mental health condition cause them to be dismissed. And so I do think that we need to do some careful thinking about how we preserve some of these specialized medical home models in order to meet the unique needs of patients who, even if someone's willing to accept the amount of payment that they bring, they're not willing to accept the patient for what they bring. So those are things that we need to think about as we're designing how providers end up being reimbursed, or how different models of care end up being reimbursed.
Yes, great point there. Gabe?
Yeah, thanks, Eve, and thanks, Janine, for your summary of this. I may be able to help fill in a little bit on terms of the funding questions. I've been involved in the CCBHC in Columbia County ever since it first got its sort of federal grant through the state. And sort of that $61 million, I'm not sure about this figure, Janine, but it may reflect that as my understanding, the state got a federal grant, and then the state administered some of those great
Right.
funds to individual clinics around the state who applied for it. And my role and involvement with this has been the Columbia County program subcontract with OHSU. You mentioned that 20 hours a week of on-site primary care. We've been sort of providing that at the mental health agency. And I think the original grants that helped launch all this, at least here, have sunsetted. And this is, as you guys have pointed out, this is sort of uh, this is a model that requires some upfront funding, and it's resource intensive, although I appreciated the analysis that demonstrates that it is almost certainly saving money in terms of reduced utilization in the ER and hospitalizations. The way, and what's my understanding, the way they've addressed the sunsetting of those grant funds in Columbia County has been to use some of the risk share dollars or some CCO money to help keep that sort of support for the primary care piece alive. But I do think that thinking about the universal health plan and sort of some of these patient-centered medical home models, thinking proactively about how to support structures like this has a lot of value to it. Just like Janine said, there's a lot of times these are patients who struggle to access primary care in the traditional settings, and who otherwise are still going to wind up in the ERs and be underserved and expensive too.
Jamie?
We had a very small experiment here at La Clinica, not going through the CCBHC route, but partnering with the local CCBHC and creating a high staff wraparound model for primary care patients, and saw $2 million of savings a year for 400 patients. So, I mean, and that was with sort of this hybrid model of using an FQHC, partnering with a CCBHC to create a place that would hold patients that otherwise would get dismissed from everybody else's clinics. And the savings when we do that sort of collaboration is even more intense. But it did require upfront funding, and I appreciate that call out.
And we got Jim and Helen, and then I think we do need to keep moving on. But Jim, your hand was up next. Jim? I'll go with Helen.
No, I was on mute.
Oh, there you go. Sorry.
So two things. First off, almost as an aside, I think I've mentioned that my grandson with severe mental illness, who at this moment has, I think, been dismissed because of behavior related to his condition. And that whole scenario is kind of upsetting. But I won't probe too far into that. But I do want to kind of, my understanding, you're sort of presenting some models for provider reimbursement. And I think we need to make sure we're not confusing delivery models with payment models. And I'm not sure where one begins and the other ends. And it sounds like this particular delivery model has a number of different payment models. And I'm wondering if, to what extent are providers reimbursed on a fee-for-service basis? To what extent are facilities reimbursed on a global budget basis. I mean, those are kind of the two ends of the spectrum as I see it. And I would like to kind of separate out the delivery model from the payment model.
Yeah. These clinics are still billing their CCO for the services, and then
On
they
a
are getting
fee-for-service
on a
basis?
unless they're in a value-based arrangement with that CCO, yes. If they're in a value-based payment arrangement, then that is adjusted and thought about as they do to make sure that they're getting that higher PPS rate. There have been a couple clinics who are getting reimbursed through other methods and got paid more than their PPS rate. They found that in the PSU study. But if say you're charging, you got, $50 a visit from the managed care CCO plan, and your PPS rate was $120, then you would get that additional as your wrap, multiplied by the number of patients there. So then you get these sort of quarterly augmented payments to bring you up to the full PPS. So, and Helen and Eve, but then I think we do need to move on because we've got other speakers.
I just want to clarify on this slide, your last bullet point about the 7 million in savings, and then Jamie just mentioned savings at her clinic. Are those net savings after what the state has put in, or is that the state puts in 61 million and then, we get, so we ended up only putting in 54 because we saved 7, or is that net?
I think it was in, I'd have to go back and look as whether what the 7 million was of the 61 or not. The national study was in comparison to the to an overall population. I take that back. This is $7 million for this one when compared to the CCO overall general population.
Okay.
Because Dr. Wallace from PSU used the all payer claims database for this analysis. So
in our analysis, we looked at the cost of those same patients before entry into our system and at 6 months, 12 months, and 24 months after engagement in the system. And that's where we got $2 million just in ER utilization alone in savings.
Eve, you had your hand up as well.
Yeah, I appreciate Jim's point about payment models versus delivery models. I think that the challenge for those of us who are providers in this space of medical homes is that it is a more expensive primary care model than a traditional primary care model. And so not everyone needs this level of service. We really need to focus the folks who absolutely have to have these wraparound supports into the more expensive primary care models. But we need to have a way of differentiating payment based on the wraparound care and complexity of care and agreements around not dismissing patients for no-shows and managing behaviors and all of those things that go into being a medical home. Otherwise, the medical homes will go out of business because they can't, because it's just more expensive on the front end. As others have pointed out, it is less expensive on the back end. We have had negative growth rates for total cost of care in our patient population 3 years in a row, which is, unheard of in this healthcare economy where things just keep going up. So good model from an outcome perspective, we have to invest in it.
All right. Helen, did you have any other additional comments?
Sorry, no.
Okay. So I'm going to turn it over to Anya, as long as the time is still okay for our OHA speaker to hang around a little bit.
I hope so, Claire. I apologize. We are running a little bit behind. If you need to jump to your presentation now, I think that might be possible. Sorry, Anya, I just talked over you, but or if you can hang on for another 10 minutes.
There's any chance. I'm sorry to mess up the agenda, but I do unfortunately have a hard stop at 3, so I'm happy to to go now, but please let me know what you prefer.
Oh, if that's okay. Sorry, Anya. And apologies to everyone for not, it's just such a, it's such a great topic. I'm just very briefly going to introduce to everyone Claire Pierce-Robel, who's the Director of Health Policy and Analytics at OHA. Let me share my screen and she is going to share briefly with us. Thank you so much. Insights around the primary care programs and PCPCH.
Great, thank you so much. And thank you, Anya, for being gracious. It's really nice to see you again. So I am here today representing OHA and to talk a little bit more about the primary care programs and where we are. Next slide, please. So I'll talk a little bit about our patient-centered primary care home program, the Primary Care Payment Reform Collaborative, our value-based payment model, and primary care spending report. So as a little bit of a history, and I think many of you will know this very well and were instrumental in designing and implementing it. So once I do turn into a pumpkin, I know that you will be able to answer any of these questions. But again, look forward to having a little bit more discussion here about how this relates to the work of the board. So the PCPCH program, Patient-Centered Primary Care Home Program, was established in 2009, and it sets the standards around how primary care should be delivered in the state around the triple aim. What's, I think, really essential to understand about the PCPCH program is that those standards are developed in partnership with an advisory committee. So they are revised every few years to reflect the current goals and the state's health transformation goals and the experience of those practices that are doing this work on the ground. So very much so a collaborative process. Those standards were most recently updated this year. Our program has a process by which they certify practices that meet the standards. I'll get into that in a little bit. And currently we have over 600 PCPCHs in Oregon, which represents about 3/4 of all primary care practices in the state. And the vast majority of Oregon health plan members get their care. So our Medicaid members get their care through, CCO members specifically get their care through a PCPCH, or 96%. Next slide. The model is based on the national NCQA model that folks will be familiar with. And it is defined around these 6 attributes that you'll see in the home graphic on the side. And one foundational attribute, which is equitable care. And as I mentioned, the standards are updated regularly, and equitable care is one of those attributes that was added most recently this year. So each of those 6 attributes are further broken down into specific standards of care. And those include up to 4 measures that determine how well a practice is implementing that standard. So what I mean by that, for example, under accessible, after hours access is a standard and a measure, whether the practice has patient appointments available after 5 p.m. or on the weekends. So that's one of the ways we measure access. There are many measures in the model. Some of those are required, 13 of those specifically, and the others are optional. The standards are assessed by practices attesting to meeting those measures, and any type of practice can become a PCPCH. So that includes family medicine, school-based health centers, behavioral health organizations with integrated primary care, pediatrics, FQHCs, et cetera. And there are then 3 tiers of recognition. So I mentioned those required measures and optional measures. Based on which measures the clinic is meeting, they can meet one of 3 tiers. And I'll talk a minute in a second here about what that means in terms of payment. As I heard in the prior discussion, kind of this question around what's a care model, what's a payment model? And this is a perfect place where that question comes up as well. And finally, I'll just mention that the health equity designation for practices is another component that was introduced this year. Next slide. So just looking at the experience in Oregon of the PCPCH program, we do see through regular and external and independent evaluations that there is a significant impact on healthcare expenditures and utilization based on patients who receive care at PCPCHs. So specifically, we look at on this slide, the most recent evaluation conducted by OHSU and PSU School of Public Health by Dr. Wallace looked at the impact of the PCPCH program and found that among those practices, patients' total healthcare expenditures were reduced by 6.3% or $76 per person per quarter, or resulting in about over $1 billion in savings over the study period from 2012 to 2019. And this is also important because it looks at what are we getting for our dollars, our primary care dollar. And while this report and evaluation showed that for every $1 we invest in primary care, we get an estimated 12 in savings from other services, including avoided costs of inpatient and acute care and emergency department. Patients also utilized more primary care. So when we look at kind of where utilization is moving and how that tracks to spending and savings, that's and really the kind of crux of and the theory behind better equipping primary care as the kind of quarterback to the an entry point to the system here. We do see that patients that utilize more primary care would have less emergency department, pharmacy, inpatient services. So exactly what we're looking for. Next slide. When it comes to payment, so the certification stands on its own. However, OHA has also utilized and leveraged the Medicaid program to provide additional incentives for the PCPCH program. So starting in 2020, OHA added this to our CCO contracts, requirement that they pay all PCPCHs in their network a per member per month payment, and to actually scale that payment depending on which tier the PCPCH reached. So as I mentioned, you can kind of get more points for achieving more of the measures beyond just those that are required for the certification. And then CCOs are scaling their reimbursement. So when it comes to looking at the additional supports, services that practices can't bill for, these aren't fee for service payments or billable services necessarily. That's what this PMPM is intended to support. So for example, hiring a care coordinator to assist patients with complex care needs, perhaps a traditional health worker to do outreach to the community. These funds can be used to also, for instance, improve electronic health records or ensure that patient documents are translated into other languages other than English. So there is a lot of different ways that these, again, additional incentive payments can be used. However, I will note that the requirement for the CCOs does not set a minimum PMPM or per member per month payment in the contracts. So CCOs can set this rate for their own practices, and you can kind of see the range here on the screen, ranging from about 50 cents to $23, depending on the CCO in the region. And it should go without saying, but I will say it out loud, that these lower payments are typically insufficient to support the work to care for patients in a PCPCH. So it's just something to note in terms of the structure of the current payment and requirements under the CCO contracts. Next slide. The next program I'll do a quick run by of is the Primary Care Payment Reform Collaborative. So this was established in 2015, again, intended to be a multi-partner group and a collaborative group that was charged with developing and policies related to increasing investments in primary care and in moving to value-based payments and aligning payments across payers. This legislation was originally influenced by a few different factors. So having seen successful work and similar work done in Rhode Island, the success as well of the PCPCH program, and advocacy from primary care organizations and legislative leadership who championed this bill. So we also have seen additional legislative support through Senate Bill 934 in 2017, which further defined the work of the collaborative to increase value-based payments, and also support critical work around ensuring behavioral and physical health integration and aligning metrics. So that extended the work that we are doing at OHA to support the primary care payment reform collaborative through 2027. Next slide. So the other place I'll focus here is around primary care value-based payment model development. Under the context of the collaborative, the primary care value-based payment model was supported through the Peterson-Milbank Program for Sustainable Healthcare Costs. So we have really appreciated the support and technical assistance for OHA that was also been provided by Valet Health, which is supported by the Milbank program. And that support has allowed for us to develop a value-based payment model. And through a work group that was, as has been the case in all of these programs, been developed through a collaborative process with payers and providers. So that work group started by agreeing to principles to guide that payment model design. So that included supporting the unique needs of adult and pediatric populations, looking at supporting practices to provide the full scope of care patients need, looking at aligning measures and models across payers, and looking to support interdisciplinary teams to support team-based care. And the model that was designed and developed is on the screen. So it consists of these 4 components: a perspective-based payment to cover the majority of services delivered in a primary care setting, also a fee-for-service payment for all other covered services on top of that. So services that would be paid for fee-for-service to encourage utilization, for instance, like immunizations, home visits, prenatal visits, end of life and advanced care planning. So those components where similarly, we are looking to encourage and not deter utilization. And then also infrastructure payments is the third component here, tied to a base payment that would be tied to the PCPCH tier, and additional payments for specific high value services and performance-based incentive payments. So this was the model that was developed in this collaborative process. But when we look at the kind of adoption and implementation, we have one CCO that has implemented the model. Some have implemented new models since the collaborative developed this with similar elements. And other CCOs already had models in place that were working for their communities, but have incorporated some elements of this model. So a long way of saying it is voluntary. It is being implemented in some places, but not uniformly so. And then the last slide I will go over here is a couple more points on the value-based payment model. So the model supports the unique needs of patients, which was central to developing this model. It is also supporting foundational infrastructure and operations through a per member per month payment. As I mentioned, being able to have non-claims-based payments to support those infrastructure needs, and also promoting health equity with the inclusion of equity-focused quality measures. So I just wanted to call out a few of these pieces that, again, are not specific to the payment side, but are expected from the care delivery models that is expected to be incentivized and reimbursed through that new payment model. So I will, my actual last slide or program was around introducing some of the primary care spending reports in Oregon. Sorry, Mimi, I'm just having you have to guess too much.
Sorry about that.
But the one other thing I wanted to mention and make sure that this group had at their fingertips is around our primary care spending report. So in addition to directing OHA to convene the collaborative, that same legislation directed OHA and our sister agency, Department of Consumer and Business Services, to report each year on healthcare expenditures allocated to primary care by Medicaid, by our public employee benefit and commercial plans. And we've since added Medicare Advantage plans since that data comes to us through the all claims database. The purpose here is to include all payments made to primary care providers. There's an additional bill that requires payers then to allocate at least 12% of healthcare expenditures to primary care by 2023. And the data that we use to assess where providers are, or payers rather, where they are in terms of hitting this target is reported by the payers. And it's generally about 2 years delayed to provide time for those claims to be delivered and the run out and analysis. And so we are expecting this summer, just to give a preview, to have that 2023 data and to be able to identify payers that have or have not met that target. So I think I will stop there because I think that's a good place to do it. And I will happy to take any questions.
Yes, it looks like Tosh, you have a question?
Yeah, so in your model, is there a requirement for the types of services that the primary care has to provide? And this question, I have seen it come often from talking to multiple specialists where they feel like the kind of referrals they're getting should be managed by primary care. So is there sort of a requirement for the types of services that primary care has to provide?
Yeah, thanks for that question. I would say generally no. The certification and the standards for the home aren't changing. For instance, the standards of care, or we're not in any way taking on the responsibility of the medical boards or the legislature to define that scope of practice. But there are more in terms of the attributes I was mentioning, things that need to be in place to be considered a patient-centered medical home, right? So timely access to care, after-hours care, telephone access, or same-day access, making sure that there's actually, from an accountability perspective, that the patient-centered medical home is reporting on particular quality measures and tracking those, are participating in a value-based payment model. So it is much more on the operational side of providing that kind of access to patient-centered care, and doesn't touch specifically the services that are provided, or that kind of those scope of practice type questions.
And it looks like Jim, you have a question?
Actually, I have a comment and I call it a cautionary note. The comment is thank you for that one slide that broke down the components of your reimbursement system into the 4 pieces. I think that's exactly the kind of model thinking that we need to as we go forward. The cautionary is my experience over too long a career in this is the more complicated you make something, the easier it is for the experts to game it. So try and keep in mind as we move forward, simplicity and transparency.
Jamie.
I had a question about the quarter of the primary care practices who are not PCPCHs. Are these primarily smaller practices who can't manage the administrative burden of reporting? Or are they urgent cares who call themselves primary care, but they really aren't primary care?
That is a great question. And Tony, I see you raise your hand. I don't know if you have an answer. It's one that I will need to take back as a homework assignment. I think my comment. Oh, go ahead.
Yeah, actually they have some very small clinics. I'm actually the clinical advisor in one of my other jobs to the program, and we have some 1 and 2 provider practices in rural areas. In fact, the very first one was on the Southern Oregon coast. So it's kind of dependent on their whether they're interested in doing the team-based model. And I think clinics that are a little heavier on Medicaid patients probably look to it because of the guaranteed payment or through the CCOs of a PMPM. There are private plans that have accepted the Oregon's PCPCH designation as a means to pay a PMPM. It's variable though, it's not all of our domestic commercial payers. So sometimes it's a mix of from what we understand. Because if they don't come to the program, then we don't necessarily know why they didn't come to the program.
No, you got to run, Claire. Appreciate you being here. Thank you so much for the presentation. Just a few comments, and thank you, Janine, for clarifying that as far as the enrollment with the quarter. I think just a call out to this is that we look at a lot of PMPM payments for the structure is for Medicaid payers, and looking at the breadth of all payers that we haven't had total inclusion, and particularly in the commercial market. And I think identification of there is a conversation going on regarding definition of where primary care is delivered and how that payment takes place. And so I think, Jamie, your call out with regard to the question, does an urgent care count as as a primary care deliverer? Are there different specialties that are qualified at that? And is the payment surrounding that should it be recognized in that pot of money? I think, many people on here recognize the imbalance of payment towards primary care and, just a consideration of, where the values and where's the return on dollars. Ms. Pierce-Roble demonstrated the return on investment from the study where $1 invested at $12 return. So I think just our thinking, our rationale, and when we're looking at this is important that there are a lot of people leaving primary care. And I think in consideration of support for this, when we think about how we invest in this is important when we look at this topic.
Looks like Angela, you have your hand up.
And I was just going to say, I apologize. I'm going to jump off, but I wanted to say if there are any further questions, I'm happy to take those offline. And hope you all have a good rest of the meeting. Thank you.
Thank you so much.
Claire.
Yeah, I was just going to add when it comes to capitation or that per member per month, I think there's different incentives, right? As far as government entities, we were part of Making Care Primary before it went bust, and they were moving towards a capitation model per member per month as well. But commercial doesn't quite have the incentives that government entities do as well. So yeah, I love the 4 pillars as well as part of the patient-centered primary care home model. And yeah, feel like that's the right direction to go into and echo, investing more in primary care because we don't want it to fall apart, right? I guess something else I would add too is just around supply, especially in rural areas. Just, yeah, I know this will probably come, just provider supply and access. And yeah, I think it's something that we brought up before, but how do we how do we not, if everyone has access to coverage and then we don't have enough providers in certain areas, yeah, does that push folks to the ER or other areas?
Eve, you had your hand up?
I would just echo that I like the model that was presented, and I think, we're going to be struggling with this push and pull of simplicity versus incentivizing the behavior that we want to see. So it will be hard to get providers, for example, to maintain extended hours on a regular basis unless we incentivize that. And it's hard to, and some of these other pieces. So I like the idea of kind of base rate and add-ons if you can demonstrate certain levels of service or that you're meeting kind of value-based goals. And certainly, I think you all have heard, I agree with the investment in primary care.
Right. Thank you all so much. I don't think I see any more hands up. Janine, do you have a wrap-up statement around that about PCPCH, or should we transition to Anya?
Hearing nothing, why don't I jump in?
Thanks, Anya.
You're welcome. So thanks, folks. I know it's been a long meeting and I'm at the end of it, and it's 6:15 on the East Coast. So I'm probably flagging a little bit. Also, the slides for this part of the presentation, I thank my colleague Janine for producing while I was out on vacation last week. But I probably won't adhere to them entirely because it's really hard to do that with slides that somebody else developed. So I'll try to, plus I want to keep your attention, and sometimes going along with slides is not the best way to do that. So I think the big question for you all for today's meeting is, do you want to recommend value-based payment methodologies, programs as part of the Universal Health Program? And if so, what kind? And so we're looking at some examples that might give you an indication of what's out there in the field now, and whether they've worked or not, and whether they should be emulated. I'm going to talk about the ACO model, the Accountable Care Organization model, which originated in Medicare. And it's relevant because, one, it has proliferated throughout pretty much all payers. And two, it has been the focus of Medicare value-based payment innovation for much of the last 15 years. And Medicare, we can't forget, is sort of has always been sort of the leader in alternative payment methodologies. I mean, Medicare invented the DRG, which is now used by pretty much all payers in the field, which was a way of lumping together services and creating some efficiencies around how hospital care was delivered. Beyond that, kind of, the fact that Medicare, ironically or not, is often the kind of the market leader in innovation in a lot of ways. Medicare also covers a huge chunk of the population, and the chunk of the population that uses the most services. So what Medicare does in terms of their payment and delivery models, and I appreciate, Jim, that you made that distinction, can often be sort of the tail that wags the dog. And so I think it's really important to know what Medicare has been up to in recent times. And the ACO model really originated with the Affordable Care Act in 2010, 2011, when Claire, who you just heard from, was back at CMMI. And I actually worked with her. I was in Vermont at the time. The ACO model is really a range of models. So CMS authorized half a dozen variations on the theme. They were staggered in terms of their implementation. They had different requirements around them, and they had different levels of risk for providers. The underlying theme for the ACO is, so you've just heard about a couple of models that are really focused on specific sort of pillars of providers: community mental health, primary care. The idea with the ACO is, can we get a bigger unit of analysis in terms of the providers who are included in this arrangement, and in terms of the services that are and the expenditures payments that are included in this arrangement, to sort of one, supercharge the incentives, get more bang from the change in payment and the incentives around changing care delivery. And two, often what happens with these kind of pillared models for changing provider payment and delivery and behavior is they don't create incentives to coordinate across providers. So the idea was, could we create this larger unit of analysis that is pretty much all the providers who provide care to a population? They agree to come together and take a certain amount of risk, financial risk, in exchange for taking some quality and cost accountability for an attributed population. I won't go into attribution because we could spend the rest of tonight. We could go to midnight talking about what is attribution, but just suffice it to say that there's a population that is assumed to be taken care of by an organization of providers that call themselves an accountable care organization. The providers across a broad spectrum, a broad array of services agree to be part of this and agree to go into an arrangement with a payer. Again, initially this was Medicare, but an arrangement with a payer where they get a different kind of payment in exchange for reporting on their quality performance and reporting on and being measured on their cost performance. So that is kind of what is an ACO, and I'm just going to look back at. So it's a value-based payment structure, it's measurement of quality, and it's collecting and analyzing data around quality and cost. Those are the sort of pillars of it. I won't go through all the details on this slide. Let's, but there's some interesting stuff here. Let's just flip to the next slide. As I said, there's a whole bunch of models. So here I count 6 bullets. I think there were actually even more than this that were launched by Medicare. Some of them have now been sunsetted. None of them, I want to say, were like hugely successful. And I can go into my opinion about the reasons for that if you'd like. But they all sort of varied in terms of their level of risk, the level of risk that was placed on providers. So did providers simply get to share in savings, which is the Medicare Shared Savings Program? And that was the predominant model picked up by providers around the country who organized to be part of these programs. Under that program, a target was set. So there's a prediction of what will healthcare cost for the population for which this group of providers is responsible. If you come in under that target, you get to share in the savings as a provider, and that gets distributed across the ACO, across all the providers who belong to the ACO. Other models had more risk in terms of there's a target. If you come under, you get to share in the savings. If you go over, you get dinged. So that's the concept of upside and downside risk. Fewer providers went into that higher risk model, but things like the Pioneer model and the Next Generation model included some of that so-called two-sided risk, where you both were held to not exceeding the budget and you were rewarded for coming in under the budget or the predicted amount of spending. There's one very state-specific ACO initiative with which I'm really familiar because I was part of developing it, as was Claire, and that's the Vermont Medicare ACO initiative. It actually was beyond Medicare, but the deal with Medicare was around Medicare. Vermont Medicaid also was included in that, and some of the commercial payers were included in that. And one of the interesting things about that is it was a statewide model. So an ACO that included virtually all providers, including a whole lot of long-term care providers in the state, that organized around the payment model, the quality measurement, and a lot of technical assistance in terms of how to do well under the model. And it also incorporated a lot of what you guys have talked about in terms of the primary care medical home. There was a pre-existing primary care medical home model in Vermont that also included integration of behavioral health in primary care. So that kind of got swept in under the ACO model. And it actually got evaluated several times by NORC at the University of Chicago and was shown to be pretty successful. But for whatever reasons, CMS decided to not renew that model and to go toward a new the so-called AHEAD model that they're now pursuing. So that model will sunset at the end of this year. And then there were some really specific models, like there's a end-stage renal disease ACO model, and there's a newer model called REACH that was really focused. It was kind of an attempt to reboot all the ACO models, take what had been learned over the last 10, 15 years, and incorporate a lot more focus on equity and access and community health, which is where the name comes from. That was started in 2023. Didn't get a lot of subscription, but there are some states that have ACOs participating in that. Next slide, please. And I should have said this at the outset. This all applies to fee-for-service Medicare. As you all probably have seen in the news, more than half of, or somewhere around half of Medicare beneficiaries are now in Medicare Advantage plans, meaning that there's an insurer that manages the deal between Medicare and individual consumers and providers. So that's a totally separate ball of wax. This is on the fee-for-service side, where providers are still dealing directly with Medicare. This was an attempt for Medicare to create, as I said, these larger kind of units of analysis for sharing risk and incentivizing quality and cost containment. In some states, there have been Medicaid ACOs as well. I'm going to skip to the next slide if you could. Next slide. This is really just background information for you all in terms of who's participating in the Medicare ACO programs in Oregon at this point in time. Next slide, I think, goes into Medicaid. No, it doesn't. So I'll just talk about Medicaid. Some states have tried to implement an ACO model in their Medicaid programs as well, with more or less success. I'd say, again, Vermont was one of the more successful ones in that Vermont convinced the Medicaid program to actually make a prospective payment to healthcare providers. And particularly during the pandemic, this was really helpful, that providers got a guaranteed, essentially, capitation payment, regardless of how many patients they saw. And that kept a lot of particularly primary care practices afloat during that time. Most states, because most states are so-called managed care states, where they contract with Medicaid managed care organizations, have to run the ACO program through a MCO, a Medicaid managed care organization. I'd say that in general, that model has been less successful. And I think that's in part because an ACO, as a provider-based organization, is kind of working on the same things that an MCO is supposed to be working on. And if they're successful, it's something of an existential threat to managed care organizations. And so that tension has played out in states that have tried to implement Medicaid ACO programs. And so some of them have not been terribly successful. I, for example, tried to create one in Rhode Island when I was the Medicaid director. And it was really, really hard to work through managed care organizations to create incentives that weren't so watered down by the time they got to the provider level that they were meaningless. Getting back to Jim's question of delivery system versus payment, delivery model versus payment model, the idea of the ACO is that it's a payment model change, but there are some requirements around it in terms of performance on cost and quality that should drive delivery system change as well. Not all ACOs have been really deliberate about that, about saying, well, here's how we're going to change our care delivery model to do better. They've more just been sort of monitoring how they've done. Again, Vermont and I think Oregon through its CCO model have been much more proactive in saying, we expect not only that you'll take on this model, this new model of payment and risk, but that you'll also adhere to certain standards around how care is delivered. Another thing I would mention is there have been sort of two breeds of ACOs that have developed around the country. One is primary care based, where primary care doctors have gotten together and essentially organized the ACO network. The other is hospital centric, where hospitals have gotten together and or a single hospital system has organized an ACO network. I haven't looked at the literature in a lot of detail lately, but at least for the first, I'd say 10 years of the ACO program, in general, the primary care based ACOs were more successful in terms of quality outcomes and cost reductions. Let's see what's on the next slide, just to see if I missed anything. No, I think I haven't. So again, you know, this is an attempt to create, and you know, you might think of it. I don't think you have to think of replicating the ACO model entirely. You do have to take into account, what does Medicare allow if you're going to include Medicare in the universal health plan. So it is totally relevant. And I think that the ACO model, in terms of its attempt to create this larger unit of analysis, which may be in the Oregon case, the CCO, and create the right kinds of incentives around that is a value. There's valuable lessons in it. But again, you may want to think more about, you know, what kinds of requirements or incentives do you put around how those networks are organized, and what kind of service expectations you put on the ACOs themselves, because I think that's proven to be both important and successful in a lot of places. And I think that's pretty much it. There was one more point I was going to make, but I've lost that. So I will, it'll probably come to me when somebody asks me a question, if somebody asks me a question. Jamie.
Thanks. I need to learn about this more because I ducked and covered during a lot of the Medicaid ACO experimentation. My personal experience with upside downside right now is that the excrement flows downhill. And so when our payer partners experience high hospital costs because travel nurses cost a lot more than nursing used to, the primary care is on the hook,
yeah,
for the costs going up. And so my concern around the ACO, and my question for you is, it seems that ACOs are in general very hospital centric models, that it's aimed at a hospital system, making all of the players in that hospital system work together with that hospital system to try to lower costs. But I don't understand how that's supposed to work when the basis of an ACO is a primary care delivery system.
Yep. So that's what I was trying to get at when I said there's these sort of two basic models. One's very hospital driven, one's primary care driven. In general, the primary care driven model has been more successful. I'll give you an example from here in Rhode Island. A group called Coastal Medical, which was the largest primary care practice in the state and probably the most advanced in terms of lots of different capabilities. and, you know, just sort of having a pretty well-oiled machine prior to this model coming along, decided to create their own ACO. And the thinking of the leadership in that organization at the time was, hey, we're primary care. We are the gatekeepers, right? We are the ones who ultimately are going to be held responsible for what happens. So let's take it on. Now that could be scary to primary care providers to say, we're going to control who goes to, control is the wrong word. We're going to take responsibility for who goes to the hospital and what kind of services they use that are outside our realm. But that really is what was intended with this model. And in that case, they were quite successful. There are other examples of systems like that that were primary care based that were quite successful around the country. Well, what did Coastal Medical do after they were successful for about 5 years under this model? They sold themselves to a hospital system. And that hospital system disbanded the entire effort pretty much. And I think, you know, if you think about it sort of philosophically, like if what you're trying to do is reduce waste, and if most of the waste is in excess testing, excess hospitalization, avoidable hospitalization, excess use of the ED, the idea that hospitals are going to really go after that waste, and as my friend Bob Murray from Maryland likes to say, cannibalize that waste, is a little more far-fetched than the idea that if primary care providers had the right supports and incentives, they would try to manage things better so that that sort of waste didn't happen. So I think it really it's an important distinction. I don't want to say that all hospital ACOs have been unsuccessful, but I think in general they have been less successful.
Yeah, I mean, I think because the premise is that we're going to do it with the ACO and focus on the hospital, when the problem is we haven't invested in the primary care infrastructure. And if we properly invested in the primary care infrastructure, those other issues would sort of solve themselves. Yeah. But when we try to cannibalize the wastes of hospitals by tying primary care incentives to them, it's upside down. And that kind of makes sense to me why it wouldn't be as successful when it's organized that way.
Right. Tony.
Thank you, Anya, for the presentation. It's kind of a good overview. My observation over the last 13 years with a lot of the pilot projects of the ACOs from CMMI and from MSSP and all the alphabet soup, as you've alluded to, is that there hasn't really been a clear demonstration on what's the intervention and what's the outcome, right? I don't know, as a provider, when we look at research and studies, we say we hold a control and then we look and see what is the intervention and what is the counterfactual and what's the change in that. And as you illustrated, my cautions with proceeding with this as value-based care is I observed the last 10 years of colleagues that are bearing the weight of the value-based care, which, as Jamie shares, is usually shifted towards primary care. The idea is to reduce people from entering the hospital and upstream mechanisms, take better care of them and reduce them as an ED visit or even going in the hospital. In this dysfunctional system, it's really hard to do that when you have several different payers and with that. So that's why we're all here for this effort, right? Is to make sure that we can create a system that wouldn't be great if everybody had Kaiser Permanente, because it is an embedded system that can do that investment and has return on that. My question to you is, if we were to tease out some specifics of one of these programs, what are the take-homes and what are the contexts? Because it does differ between a practice that's two providers that can't really manage in an ACO versus a larger entity that is a big health system. And it is, so some can take upside risk, some can take downside risk, and in thinking through those and these equations. And it's just, I think it's hard for me to wrap my head around that when we're thinking of this and putting in place if there is clear research where there's demonstration in this size health system or this provider side. But I think the problem that as I'm just even speaking this out loud, eventually, you know, the constructs we're going to have, perhaps if we put this in place, may not be the exact same. And then I'll just throw another wrench into this is when we look at, you know, other models, when we look at Connecticut, when we look at their change in their Medicaid delivery system, they have foregone doing managed services. And they've actually seen a 14% reduction in their total spending over the course of the implementation. So they've removed, and they're solely on fee for service in their Medicaid population. And I think that's a model that's an interesting look for this question. Particularly with the burnout and again, the water that Jamie carries, you know, in being a primary, or Gabe here delivering primary care, and the thousands of things that we have to do. And I'm just going to rattle on here because I get the floor. Is I'm very curious about the patient-centered primary care medical home. When we've looked at CCO's interventions and at the time frame, which one really was the stronger intervention? Was it changing us to have a stronger primary care medical homes, or is it the model we've gone with ACO models for CCOs? And I haven't really seen clarity on teasing out, again, getting back to the question of what's the intervention and what's really leading to that. So I've thrown a lot of wrenches into this, but I think there are questions that we need to be thinking about before we move to something where we put two-sided risk and push practices to places they can't manage that. I think the intervention for accountability, coordination of care, we've done very well with our CCOs. And I think that the value which you get with an ACO is accountability, right? Have some ownership of the outcomes. So I'm going to wrap it up in a bow. If we could look at the specificity of some of these ACOs, whether it was in some of the smaller sites of an MSSP or the REACH program, I have my doubts about that, but it would be clear, it'd be interesting to take a look at those further with answering a question, do we adopt these in this model moving forward?
Yep. There's a lot in there. Thank you. So first I would just say, I think evaluation of ACOs, and even if you just leave it to the Medicare ACO realm, is really difficult. It was made difficult by the way that CMS implemented it in terms of letting too many flowers bloom and underpowering all of their models, so that and I should just say, this is Anya speaking Anya's opinion. So this is not HMA doctrine. It is not anybody else's opinion. I don't think that they produced models that really put enough incentive, financial incentive in play, so that it was, so that we could test whether that made a difference with providers. That was the intent behind it all. Like, if we create the right economic incentives, they will do the right thing. And I don't think we know that. And part of that is that Medicare really limited the scope of the payment change under their models. So for example, I worked for a health system that was part of that Vermont ACO. We didn't know until 18 months after the performance period whether we had done well or poorly. And we had no idea what kind of reward or ding we were going to get under the model. That's too far removed from your behavior tomorrow for you to really change what you're doing. The other, so one concept was economic incentives matter, and I think that they really didn't put enough behind that to test that notion. The other is that you can create a virtual Kaiser, basically, right? That you don't have to have a Kaiser, you don't have to have a single organization. You can create these affiliations, and that will be enough. In my opinion, what we learned is it might be enough if that virtual organization is really committed to doing a lot of things that are going to change the relationship between providers, the information sharing, include a lot of technical assistance, and a lot of very deliberate practice change. like just creating the virtual organization around the payment structure and the reporting of data didn't produce much at all. The ones that were more successful made a real investment. And I assume that some of this was true in the Oregon CCOs. I'm not as familiar with that, but that the ACO or ACO-like organizations that were successful really put a lot into that sort of infrastructure, technical capacity development, which was tough under these models because you had to put that money in up front and hope that it came back to you. And in a lot of cases it didn't, and that's why people withdrew from the programs. I think the Connecticut situation is really interesting. Vermont is also, they call themselves a managed care state, but they're not really a managed care state. There's no MCOs. And I won't go into how they managed to pull that off, but they're basically a fee-for-service state. I was Medicaid director in Rhode Island, as I said. I was paying 8-9% administrative fee to MCOs, and I would say to myself every day, why? What are we paying for? I don't see any value add in this. So I'm not surprised that Connecticut has flipped back and forth over the years, but it's not surprising that they would get away from that 8-9% admin and do just as well or better in managing the program themselves. So that was a lot of my opinion. Excuse me.
Although both Connecticut and Rhode Island, they have national health plans, and Oregon CCOs emerged locally and are more regionally. So it's hard to make a direct comparison.
Yeah, I think Oregon I wouldn't put it in the straight managed care. I'd put it more in the sort of Vermont-ish bucket. I wouldn't put it in the straight managed care bucket. Yeah, I mean, yeah, enough said by me. Tosh.
Yeah, hey, Anya. And this question may also not be for you, but maybe for everyone. I'm very curious as to what other countries who have universal healthcare or single payer system, what are they doing in terms of paying providers? And I ask that because I see Canada, where there are many provinces where people shouldn't technically live, but people do live there. They have providers and they have good outcomes. So I'm very curious as to what other countries are doing. Taiwan as another example. People live in the mountains and they get care. So I'm very curious as to has there been any kind of research done by our group to evaluate their models and see what kind of success they've had. Also, I'm very curious as to in US, has there ever been any kind of models that have been implemented to look at specific disease states and see what is the cost for that disease state, for managing that disease state on a long-term basis? Because the cost for hypertension cannot be the same for diabetes or something else. So I'm very curious as to when you break it down per disease state, how expensive is that disease state and how expensive is the management? And then can we come up with something where we pay the providers for managing those disease states? And in the same aspect, when you look at the population as a whole, you may have 40% who have very complicated disease states, but 20 to 30% have very minimal disease states. So when you sometimes I feel like the conversation gets very convoluted into those complex diseases, but if the other people who are not burdening or does not have a complex disease state and are not burdening the system, then how much are the resources that we're utilizing as a whole? And can that be something to steer forward, what kind of model we want to present? I don't know if that was a lot of babble, but thank you.
It wasn't babble, no. In terms of other countries, I am not an expert on all other countries. I will say, I do teach national health policy, and we do 1 or 2 sessions on international health policy. And so I'm familiar with some of the variations on the theme, but you can see everything, from doctors on salary, everybody on salary, budgeted systems, budgeted nationally, budgeted regionally, to systems that are where the payment and structure is much more like the US, to everything in between. We are uniquely sort of, we have the unique distinction of being the only ones who pay this much and don't cover everybody. But otherwise, you can kind of see everything except that particular set of characteristics that we keep to ourselves. Specific disease states, I think that was part of the idea of the ACO is, look, if we create the right incentives and organize providers around reducing the cost of care and keeping up quality, they will go where the savings are. They will go where the better management will lead to rewards. I think you probably could find some examples of that, but again, I think the models were probably too underpowered to do that. The only really distinct, disease state management models that I know of are the end-stage renal disease model, and I am not really familiar with what the results of that have been. And ESRD is such a kind of unique thing in the country that I think it's hard to generalize from that. And then outside of the ACO model, CMS has pursued so-called bundled payments for specific things, not as much in disease states as in episodes of care. So, a time-limited episode like a joint procedure, or I don't know. You guys are all docs, so I hate to
MIs.
A delivery. Well, there's
Mhm.
episodes of care for like maternity,
Yeah.
for sure, and some cardiac procedures as well
Right.
have been
So something
tested.
where
And
there's like a kind of a known course of events, known likely duration of care, and a group of providers usually cutting across acute and post-acute care gets a lump sum payment to manage that. But it hasn't, it has generally been like 6 months at most in duration, not kind of like a lifetime management of disease state sort of thing. And part of what we suffer from in this country is that because people are on commercial or Medicaid coverage, and then they turn 65 and they're on Medicare coverage, no payer has kind of responsibility for that longitudinal look at the health of the patient, and that really undercuts some of these programs.
I think I'm
Jim.
going to let, I was going to say, I
sorry.
think just so Helen can jump in here because we only have 10 minutes left. This has been such an amazing, so I wanted, Helen, you hop in there.
Well, I was just going to interrupt to say we should take the last 10 minutes to kind of reset for what our next plan is. This has been really rich conversation, but I think we should pause and kind of set some expectations for where this is going to go next. Thank you so much to everybody who came to the meeting to present today. I'll send gratitude to Claire too, but Janine and Anya, thank you so much. This has been really great information.
You're welcome.
Yep.
And as far as I know, we did not have anyone signed up for public commentary, oral public commentary. Is that correct, Isabel? I didn't check 2 days ago.
That's correct.
Okay, so you can take it away, Helen.
Do we have the last couple of slides?
Hey, Helen, can I just interject? And I think that last comment, as far as bringing it back to the conversation and kind of next steps, I would be curious if we could find some time to explore more of those specifics of other countries' payment forms and what they've used for value-based payment or not. Just in regard to this question, if we could put a pin in that, just to look, what we're looking is risk contracting. Does that have value in this moving forward? And be curious to see what other and I think other states, kind of as we've illustrated some of that, would be a good exploration.
Right. Yeah, no, absolutely. Yeah, we can look into that. So I want to just give people a quick orientation. So Mimi, do you have the 2 slides that I sent for this part?
I do. Let me just pull those up. Oops, sorry.
So, you know, the legislation that created our board set some parameters for us that we need to at least make an attempt to follow. And then, of course, as we always keep alluding to, the task force that preceded this board came up with really specific recommendations. So moving forward, when we talk about provider reimbursement, I want this group to just kind of keep this structure in mind, that what the legislation says is that there will be a public corporation that's going to operate a universal health plan. It's going to live at the state level. It'll be governed by a governance board. There will be a fund in the state treasury, which is all of the state's healthcare dollars. And the legislation says that the state is the only risk-bearing entity. We can set that aside for now, but I just want to point out, like, so the blue diagram is sort of like a rough structure, and then the orange circles are what are assumptions or specifics that were called out in the legislation, or possibly recommendations from the task force. But these are kind of like some underlying assumptions. So the legislation also says that there will be regional entities around the state. And the job of these regional entities is to coordinate the local care. It's to provide an option, you know, an opportunity for community voice to be involved. It's to assess local needs. It's to support the providers with payment, quality, risk assessments, all of that. So the idea is that there would be risk-adjusted payments through these regional entities. But as it stands now, the regional entities themselves would not be risk-bearing. And then, you know, within the regional entities, there are hospitals and clinics, of course. The legislation does suggest that hospitals would have global budgets, but it doesn't make any provisions beyond that in terms of provider payments. So when we think about how primary care, specialty care, behavioral health, dental, and then all our ancillary services would operate in a system that looks like this, it's really undefined. And the board is going to be taking on some of the bigger questions around risk and where we should bear risk, and what these regional entities look like and how many there are and sort of what the kind of guidelines about them are. So those are board level questions. But within a system that looks like this, if there were a regional entity getting some portion of the healthcare dollars of the state, and they were sort of the only bucket of money for a region, how would that work for primary care? Like, and so you can go to the next slide. I think, you know, obviously dealing with specialty care in the hospitals is a big thing, but what I'd like this group to start with before we do anything else is think about how primary care would operate in a structure that looks like this. The legislation says that all clinicians and hospitals will contract directly with the state. So again, we have to sort of, at least if we don't think that's a feasible plan, like why that's not feasible, but how would that work? Would they contract with regional entities? Would primary care clinics and systems have the option to bear risk themselves and be a capitated entity? What would be the relationship to specialists in this model? So obviously a lot of health plans now require a referral to a specialist. And so in a system where there's one bucket of money for a region, what's the relationship between primary care and specialty care? Are there still referrals? How does that work? Can people see any specialists that they want, anytime that they want? Who determines that? You know, and related to that, how would we look at utilization management? Right now, prior authorizations are, you know, a very common way to manage utilization within a health plan, but those wouldn't exist anymore. And so how do we manage costs and utilization in a system that look like this? Should there be quality incentives? Are there fee-for-service options? If we have, I mean, I shouldn't say that, like, given that we have so many PCPCHs and CCBHCs, how do those rates get set? And then what proportion of the spending of this region should go to primary care? these are, and we're obviously not going to touch on these today, but these are the kind of questions that came up for me when I started thinking about how primary care would operate in a system where there's one pot of money at the state, and that one pot is somehow distributed to these regional entities. And then how do we take it from there in terms of how primary care gets paid? So we've already identified a few folks who are willing to do some background research on this and some thinking on it, and then bring some ideas to the larger group. Who was that? I know it was Jamie, I think Tony. Who else was involved with that?
Betsy was.
Was
Right,
Mike?
because I have my notes on my screen that's covered, so
Was
I
it
can't
Mike?
quite get to it yet.
Mike Durbin, or I thought, or no?
Yes.
Yeah. Okay. And then, so given our discussion today, I want to open it up. That we've got a group of people who are going to spend some time between now and our next meeting thinking through some of these questions about how primary care should operate in a system that looks like this. If anybody else would like to join that conversation, you can make yourself known now.
I'd be happy to engage.
Is that Eve?
Yes.
Okay,
That was
great.
Eve.
And forgive me if I didn't mention you before, that I just did that purely from memory about who was involved before. So if somebody else has already said they want to be involved, I didn't mean to miss anybody.
I'll be happy to join too.
Who's that?
Tosh.
Tosh, awesome.
Yeah.
Great.
We just need to be a little conscientious about keeping it less than a quorum of this committee.
And so this committee has currently how many members?
That's a good question. I'm just going to stop sharing my screen right now and look at the agenda.
I believe there are 17.
Okay, so it can never be more than 8 people involved. But I think, if I'm guessing, I think there's like 6, 7. Tosh, Mike, Eve, Jamie, Tony,
Rob volunteered as well.
Rob,
Betsy.
and Betsy. Is that everyone? That's 7. That's awesome. Yay, 7. Okay, so everyone knows that's the public meetings law, is that we can't convene a quorum, and that this group, the job of this group is not to come up with recommendations for this committee, is to do some background thinking and research and present this committee with some ideas and options. But you cannot make recommendations. You just sort of present sort of your thinking and background research to help inform our discussion. And then we will all participate in the discussion and make a decision together. Cool. Awesome. This was a packed meeting today. Thank you all so much for your attention. Deep gratitude to the staff and consultants who helped us out with this complicated topic. It's a lot to digest. We can all go through the slides a little bit more, and we will be continuing this discussion for the next couple of meetings. So thank you all very much for your attendance.
Thank you, everyone.
Thank you,
Have a
everybody.
great afternoon.